our day-to-day is implementing federal and state laws and regulations, and changing as best we can to the current healthcare landscape, and that takes a lot of time and effort. The reason for the quality and population health, and you are going to hear me say this a lot, is because we want to change that. We want a team dedicated to diving into our what is the health of our population, and what are the things, and somebody's health, only 10% of somebody's health is healthcare services. The rest is food and education and clothing and housing. So, CMS, the feds are moving towards allowing state Medicaid agencies to incorporate social determinants of health. So that's where we're moving to, and that's what that division is really, we have a lot of expectations for that division. And our MCOs have moved that way through their value-added benefits as well. A lot of them have food programs. Somebody being discharged from the hospital, they have a food program available to them. Food is medicine. It's important to address obesity. So, but a lot of those things, as we have all discussed here, education and the obesity of our children, and those are things that are outside of our control. But we should be working across the sectors to address them, and we appreciate the engagement.
I just think as we keep having conversations about the numbers on Medicaid, we need to understand better what that means and where can we have an impact. We have jobs coming to this Commonwealth. If there is a large segment that's what the issue is employment and poverty, we can affect that. But it needs to be, for some of you folks that might be listening that are running for governor, it might be something to look at. And there may be some answers there where we can make progress in various areas at the same time. If there's a focus on data and on regions and on populations, and it's a win-win for everyone. But I'll leave it at that, Mr. Chairman. Thank you.
Thank you, folks. Here we are in the home stretch. We have Representative Raymer. I have a couple of questions, and I'll allow Chairwoman Mosier to finish. So, Representative Raymer, if you would.
Thank you, Mr. Chairman. My question's kind of similar to Senator Carroll's. Looking back at the 56% adult population that's in Medicaid right now, I'm interested in the part of that population that does qualify for income. Do you have an average on how long they stay qualifying for Medicaid, how long they stay on it? And also included in that 56%, would there be individuals that are also like dual covered with Medicare? Are they included in that number? Thank you.
So yes, they are. Couple of things. One is, since the pandemic, so for the past 3 years, we've been keeping people covered, and so even if their income might have grown, and one thing I didn't mention, but we're the payer of last resort. So if somebody is on Medicare, or somebody has employer-sponsored insurance, or have some other coverage, what we call third-party liability, we're the last payer. So they take primary payment for that. But we, for the expansion population, I don't have, unfortunately, in front of me, what that population has looked like since we expanded in 2013. Certainly, we'd be happy to provide that. And it's not the majority of our population. Our majority of our population is age, blind, and disabled. The traditional population.
But I think, in answer to your question as well, I think I've seen some national data on how long folks stay and receiving Medicaid, but we'll try to find it for you. I don't know as we have Kentucky specific, but we'll see what we can find just around eligibility programs in general. That may be easier to do than a specific population, but we'll give it a shot.
A couple of questions I have for you. First, have I ever mentioned that I think we have too many managed care organizations? Just throwing that out there. I know I had. You mentioned network adequacy. And we had a presentation from the MCOs this summer, each one of them. And each of them kind of touted themselves that they did such a great job, 95% threshold. Then we asked Dr. Stack during his presentation if he agreed that that number was real. And I'm paraphrasing, but in short, he said, no, it's not. And are you aware that 40% of the population of the state is rural, but only 17% of our primary care physicians practice in rural Kentucky? So how can we say that we really have network adequacy? And this is a debate we have all day long. We've got issues with waiting lists for Michelle P. Waiver and a couple others that we all want to see filled. This last budget session, we heard, I don't know from how many healthcare providers about payment inadequacy. We were able to address some of them, some we were not. But we've got an issue. And you said we have limited resources. We know that. Appreciate the partnership we have you folks. It's tremendous partnership, but it bothers me to no end that we've expanded Medicaid benefits under emergency regulations for dental, vision, and hearing from $50 million that we've saved from single source PM, which previous administration cabinet fought. They said, no, that's not going to be a savings. As a matter of fact, it's going to cost more money, but we've saved at least $50 million, and we think going forward it's going to be equal to that. But we committed those funds to expansion of programs rather than addressing the need that we presently have. And this isn't new. We talked about it in Medicaid oversight. We talked about it in health and welfare. We talked about it in budget review. But we expanded services that are empty promises. Dental services, they're not out there. Reminds me as a hospital CEO, I got 4 weeks of vacation, but I could never take 4 weeks vacation. Maybe 2 on the average. But my bosses decided they were going to reward me by giving me another week's vacation. Really? Can't take what I got. But we're offering a service that there's no providers there to provide the need. It's an empty promise. It's just a shell of a promise. And I don't understand why we did that, but particularly how can we do this under emergency regulations when specifically our KRS says you have to be able to document that? How do we document that?
So as a question, yes, we have expanded for dental, vision, hearing, and
need the waiver program. I got people that can't get acute care. We're not meeting those needs, and I think they're as important as any other. But again, how does that qualify as an emergency regulation? There's supposed to be some documentation, some substance of this, and the best I can determine, the only thing that we presented as part of support for this is the press release from the governor. That doesn't qualify under this particular statute, at least I don't think so.
Well,
so where's the documented need? Show me the data.
we will be happy to do that.
Well, can you understand my concern? Again, I think we got this great partnership, but when we express that that's not the sentiment of the legislature, because now we have committed $40-50 million year in and year out to this endeavor, when we think there's other needs for it. Could be better needs for it, but we don't even get to have that conversation. But I think it's abuse of KRS 13A.1901A that says you've got to be able to provide documentation that this is an emergency. And nothing in support of that proposed regulations documented an emergency. Nothing.
I doubt very seriously I'm going to convince you today.
Well, I guess this is one of those that we will always agree to disagree on, but that's disturbing that our concerns and comments were not heeded, were not taken into account, and you just went ahead and did what I don't think is in the best interest of this Commonwealth, particularly in the dollars that we had committed for the future. Those dollars should have been a part of the budget process. It should come back to us and said, how do we want to spend these dollars? And it could very well have been, we'll do additional dental, vision, and hearing. But we don't have that opportunity now. We don't. And I think it's a kind of a breach of trust, and it bothers me greatly, but I'm not going to belabor the point. Chairwoman Mosier, I'll let you finish.
Thank you, Mr. Chairman. And I'm happy to kind of wrap this up. I do remember my question, but on the last topic about the dental expansion, I understand fully that patients have a need, and they do end up in the emergency room, and it's a higher rate of cost to the system. But what we don't understand, I think, about the dental expansion is this actually addressing the low reimbursement rates? Because we have dentists who will provide the service, but they haven't had an increase in their reimbursement for, I think it's going on 20 years. So that's what we should have addressed, not expanding. We don't want to add a sunroom onto the house with a leaky roof. We want to fix what the actual problems are. So that's my 2 cents on that. The question I had was about the new division that you mentioned, the quality and population health. A lot of times when we introduce legislation, we talk about new policies, we talk about return on investment. And I'm wondering if this new division is going to have the capability to help maybe audit what's going on in Medicaid, look at some outcomes, and help us actually determine some of the return on investment as we really try to our best to target Medicaid dollars to programs that work, because we can expand it all day long. We see the budget problems that the state is encountering now. It's getting worse. How do we actually audit the programs that we have and determine what's working?
That's the population health, I think, piece to that. And this division does have its own research and analytics team for that reason, because we do want to dig down into what are we spending our dollars on, what does give the biggest bang for the buck. And I think it's hard to understand that allocating resources for a service might not mean the same if we moved it to something else, because it doesn't cover as much. And those are some of the decisions that we have to make. But yes, certainly, I think, Representative Moser, to your point, yes, that is one of the expectations of that division, is to help us look at what are we currently covering, where should we focus our efforts, and that's what we're wanting to do.
Good. That's good to hear, because we do need to understand the feasibility of the programs that we seek to really help us with these horrible health metrics that we hear about continuously. So thank you so much for your presentation today.
You're welcome.
We are so appreciative. I know that all of the members here, this was a pretty brief, 2.5 hours doesn't seem brief, but seriously, we could spend all day on this. So I'm sure there are lots more questions. I look forward to working with all of you this session. And I guess we should just say that the next joint meeting of the Senate and House Standing Committees will be next week, Thursday, January 19th at 12 p.m. noon, same room. And we will try to give all members, especially new members, an overview of the opioid issue. We have some really good updates on the opioid abatement, CORES funding, Senate Bill 90. I know there are several things that we're going to try to touch on. So come back next week, and thanks for being here today. I believe, without further business,